Hello, and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comps. I'm joined today by my fellow editor, Annie Joseph. Annie is a clinical microbiologist at Nottingham University Hospital's NHS Trust in the United Kingdom.
Hi, Angela. Good morning.
Today, we are really pleased to have back on Communicable Professor Catriona Bradshaw in Melbourne, Australia. Catriona is a clinical researcher and head of research translation and mentorship at Melbourne Sexual Health Centre, School of Translational Medicine, Monash University, and Alfred Hospital. She focuses on translational research to improve treatment and control of sexually transmitted infections, including the development and implementation of resistance and point-of-care diagnostics, antimicrobial resistance, and stewardship in STIs, as well as strategies to optimize reproductive health. Catriona is an NHMRC Leadership Fellow, a center head for the Center to Impact in Antimicrobial Resistance at Monash, and a co-director of the ARC Research Hub to combat antimicrobial resistance. Cat, welcome back to Communicable.
Thank you. It's really great to be here.
So, Kat was our expert guest along with Theodora Wee of WHO back in January when we talked about supergonorrhea and other sexually transmitted infections. And at that time, Kat referred somewhat cryptically to a large randomized trial whose results might change the way we look at the role of men when women get bacterial vaginosis. Well, that trial was published just a few weeks later in the New England Journal of Medicine, and its results are pretty intriguing. So we've got our back so that we can delve more deeply into this trial to understand what it means not only for bacterial vaginosis, but maybe for other STIs, and maybe even for UTI, which is something Annie and I are very interested in.
Oh, yes. But first, as our listeners know, we start these episodes with a get-to-know-you question for our guests and also our hosts. So here it is this week. If you hadn't gone into medicine, what field or career did you wish you'd done instead? So I'll start. And for me, it's still science, something I've sort of fallen in love with only in the past few years, and it's paleoanthropology, so the study of ancient humans and human ancestors. And I think I'd quite like to have been the person digging up Neanderthals and piecing together evolution of humans. How about you, Angela?
Very cool. We did have a similar question on an earlier episode. So I've answered this question, I think, in some other iteration. So I have to be consistent. And I am consistent because my answer would still be travel writer. I don't think I have a very well-formed idea of what that would actually mean because my image, and we're talking sort of ideal, right? Dream job. My image would be that I would get to travel and to write. And that is what I said and what I'm saying now. It's my story and I'm sticking to it. Kat.
How funny. I think our worlds sort of intersect. So I was brought up in a household where my father wrote on evolution and we spent a lot of weekends looking for fossils, and he was absolutely obsessed with that. So I feel like I lived a lot of that during my childhood. And I too wanted to be a writer for the Lonely Planet. But actually, that came a bit later, my dream job, which my father spent a lot of time talking me out of, was to be a marine biologist. That I might have limited job opportunities and medicine was a better option.
Aww.
And that medicine would help me travel the world, which it did, actually. So it sort of helped me be a bit of a travel writer because I spent time in Africa and we travelled a lot.
Okay then, Catriona. Before we start talking about the big trial, are you able to give us an overview on what the evidence was saying on the role of sexual partners in bacterial vaginosis, BV, we'll use from now on, in transmission and recurrence?
Yeah, so there really is a wealth of published evidence to really show that BV has the profile of an STI. So if we look at incident BV, so acquiring BV, we see that consistently associated with new partners, changes in partners, lack of condom use in numerous observational studies. It's also associated with early age of first sex, and it's rare in women who have not reported sex with others. It is really strongly associated with onset of penile vaginal sex, but We also see in couples with two vaginas incredibly high concordance for BV, so 80% concordance for BV. So their microbiotas really align, and there's a lot of evidence for that. And in contrast, if we study recurrent BV, it is consistently associated with one dominant risk factor, and that is ongoing exposure to a regular partner. And that pops up in all your treatment trials if you bother to collect that information, and you just cannot adjust it out of analyses. And that can be a male or a female ongoing partner. And obviously that speaks to reinfection, because that's exactly what you would see with chlamydia, for instance, if you're not treating a regular partner, because the probability that that regular partner is infected is far higher than the probability that a casual partner in the general community is infected. We also see these BV bacteria in two anatomical sites in men, in both the urethra and the cutaneous penile microbiota, so particularly under the foreskin. And we see them in the male partners of women with BV far more often than in the male partners of women without BV. And a really nice study by Supriya Mehta in Chicago, but done in Western Kenya where she works, showed that the penile microbiota was highly predictive of incident BV in female partners. So collectively, we have this really, really overwhelming body of epidemiological and microbiological data that spans actually decades to support the role of sexual partners in both the acquisition and the recurrence of BV.
Are the men in any of these studies ever symptomatic themselves, besides obviously, the usual suspects, but actual BV?
Yeah, so they're always described as asymptomatic, and there's occasional sort of case reports. But actually, you have plenty of men that come to you that complain of a smell. In uncircumcised men, that same sort of fishy odour. And as in women, there's smellers and non-smellers. So, if you've got allergic rhinitis or chronic rhinitis, and genetically some people seem to smell it or not smell it. Now, after 20 years of working in this space, there are mild signs, but I don't think there are any intraurethral symptoms associated convincingly yet with BV as a syndrome, but possibly with some specific bacteria. But we really need to look more in that space.
I'd never thought about symptomatic men with BV-associated bacteria.
It's subtle. It's not sort of something that people generally race in. But some men are very fastidious about their hygiene and very disturbed by it. Then there's a lot of overwashing that goes on and this and that.
I was going to ask a bit more on the microbiology side of things. Gardnerella, which is the one that everybody kind of remembers. But what about the other BV-associated bacteria? Are there others there in the mix that we should know about?
Yeah, I mean, this is so frustrating, this condition, because we love in medicine to distill everything down to one infectious etiologic agent that is present in someone with disease and absent in someone without disease. And we can't do that for BV. What we really actually don't know if BV from the outset is initiated by a single founder organism, with Gardnerella vaginalis being the sort of favourite at the moment. And does that come in through a transmission event? And does that set up camp, displace lactobacilli and bring its friends in? We know that there's these synergistic relationships between bacteria, and people have tried to look at this and whether there's a sequence of events. And Christina Musney has published beautiful hypothetical models on this, with GVAG coming in, setting up camp and secreting amino acids and inviting Prevotella in. And these guys, Gardnerella vaginalis has quite certain strains. We now have about 13 different strains. So we're talking about a pathogenic subtype within it, not just all GVAG, but good adherence characteristics, good biofilm forming characteristics, secreting amino acids that Prevotella likes, and inviting in the other friends. And so we have organisms like Sneathia and Megasphaera and other fastidious BV-associated bacteria.
Which many of us wouldn't have heard of, right?
Well, they are all part of, if you go back to looking at sequencing data. They are all organisms that are very much part of a suboptimal microbiota or community state type, however you want to define it. And that suboptimal community state type correlates quite nicely with Nugent BV and correlates quite nicely in epidemiological studies with bad outcomes like increased risk of acquiring STIs and HIV and obstetric sequelae, etc.
Should we take a moment here to ask you, what is Nugent BV? Can you tell us what the Nugent score is?
Not only do we not have a clear single infectious cause, we're stuck with slightly suboptimal diagnostic tests. Although as time goes on, I'm not sure how suboptimal they are. They actually capture the clinical syndrome quite well, particularly Amsel's criteria. So the Amsel's method really relies on 4 characteristics. One is the presence of this discharge, which is really quite a milky sort of discharge. It's not that thick, curdy, cheesy, thrush-like discharge. It's quite thin. I often say to students and trainee doctors, it's almost like the vulva's just sat in a saucer of milk. You get this sort of glistening, almost translucent discharge on the outside. Things are a bit sort of shiny, a little bit opalescent. Pop the speculum in and you might have this sort of giant puddle in that posterior fornix. And that's the effect of exfoliation of vaginal epithelial cells.
And in the manuscript, you say it's got to be homogeneous, right?
That's the definition. Yeah, look, the reality is it can be hard, particularly as a non-expert, but also it's really not a very precise thing. So
I think it's the only one of those criteria that is not entirely objective, right? It's not subjective.
And also women have often cleaned out the discharge. They're embarrassed. It's not there when you see them. So yes, it's the problem criterion. Now, when you lose your optimal lactobacilli, you actually lose your lactic acid and you get an elevation in your vaginal pH. And so that goes up. So we all know that healthy vaginal pH is usually less than 4 and over 4.5, but quite frankly, 4.5 is not normal. So that is your alkaline pH that reflects this sort of loss of this lactobacillus dominant environment. So that's one of the criteria. That is an absolutely essential tool for clinicians. No one should examine a woman without pH paper at 0.5 increments. You've got speculum in, swab, roll it. The minute you can see it's alkaline, it's either going to be trich or BV. Yes, it can be blood and it can be semen and it can be mucus, but frankly, it rarely is any of those things. If it's blood, it's very obvious it's blood. It ruins your pH anyway. So that's your second. Your third and fourth rely on access to a microscope. And so your third criterion is the positive amine test. Now, this was developed with a drop of vaginal secretions popped under a cover slide. Off it goes to the lab. People look at the wet prep, flick the cover slip off and put a drop of potassium hydroxide on it. And that liberates these volatile amines. And so that you then say you can smell them. Well, if you can smell that smell on clinical examination, that's a positive amine test. You don't need to be doing a tiny drop of vaginal secretions that's half dried out by the time it's got to the lab. I mean, you write positive whiff test if you can smell it. And then the fourth, which is the most specific, are clue cells. Now, clue cells are exfoliated epithelial cells from the vaginal walls that are coated in biofilm so that you see, these classic epithelial cells just coated in these gram variable coccobacilli, supposedly obscuring the borders of the epicells and making up more than 20% of your epicels. So all of these definitions have been used and you can somewhat loosely interpret to a degree because this is not a normal state. The normal vaginal microscopy doesn't look anything like this at all. You've got this beautiful acidic pH. You've got these scant bacteria. You've got these lovely pink epicels. You see a few purple gram-positive rods floating around that are your lactose. And that's healthy, and everything else that isn't very healthy.
To the trained eye, it's easy. Yeah.
It really is. The Amsels are easy. And I say to people, without a microscope, what you can do is record the discharge, the smell, and the pH. So you can, at least if you have 3 out of 3, it's going to be BV, right? And you could get into a bit more of a mess in a high trike prevalence environment. We don't work in a high trike prevalence environment, but that's where it can get a bit trickier. The Nugent score, or the Nugent method, and in the UK they use ICE and Hay a little bit more. All of these are scoring methods that effectively score that pathogenic process of loss of lactobacilli. So for the Nugent method, 0 to 3 are those lovely pink epithelial cells with no gram variable coccobacilli, lactose, and then your 4 to 6 is this intermediate state where you're starting to lose your lactose, and you've got some gram variables, coccobacilli, but you still see a few lactose floating around. That keeps you in this 4 to 6 range. Now, in our clinical service, 50% or more of women who have intermediate flora, microbiota by the Nugent method, they actually have BV by AMSLs. So for us, we use AMSLs and we ask. For 20 years, we've asked our lab to report both and our clinicians to report both. So we do both, and we define BV, which a lot of people now do in trials, as 3 to 4 AMSLs criteria with a Nugent score of 4 to 10. So you don't have anyone accidentally sitting in there with a 0 to 3. And you can really review the slides if you think they're out of whack with each other. And you might find that people are miscalling. And so this relies on a lot of expertise with microscopy, which is a dying art in the world of private medicine, but even in busy hospitals. But it is so wonderful. We have this at our service. It enables us to, within 10 minutes, say BV, trike, candidiasis. Everything looks normal. This is physiological. It's truly fantastic. And so 7 to 10 then is like full-blown, no lactose, and you get into the higher thing if you have these little curved rods, which were thought to be mobiluncus and are now considered to be, I think, BVAB1 or something. But anyway, it really requires expertise to recognise these and to understand normal and to be able to differentiate these morphotypes. One of the things that we're planning to do and plan to do for ages is the difficult, tricky slides, where we have a mismatch between our microscopists to sequence the damn things to look at what's going on and see whether there's an abundance of some species that's causing problems.
Oh, that'll be a good one.
I think it's so interesting that there's a condition still, like in 2025, that we rely so heavily on manual microscopy and like the expertise of the microscopist. It's amazing, really. I'll tell you a side story, is that my office is just like off the main micro laboratory, and we had a little move around of things, and the genital bench ended up right outside my office for a few months, and I could hear the microscopist going, oh lovely, another lovely one, and training the more junior staff. And there was this guy who must have been, oh bless him, he looked like he was on work experience. He was maybe 18, 19, and one of our really senior scientists was like talking him through the vaginal microscopy, and she was saying, you see this one's just beautiful, the vagina is a beautiful flower, and this poor kid, he looked like he wanted to die on the spot. It was so funny.
We need more people like her.
Yeah, I mean, it's interesting. I'm really glad we're having this discussion before we even start talking about your trial, because clearly in Melbourne it's different, and apparently also in Nottingham. But in my center, BV, everything sort of, let's say, down there is not dealt with by infectious disease doctors. That goes to the gynecologists. We do UTI. That's where I come in. And below that, it is not infectious disease people. So I'm not sure our listeners are entirely familiar with AMSL's criteria, with the Nugent scoring system, or any other scoring system for that matter. It's good we're hopefully laying the groundwork. So without getting into the results just yet, Kat, can you briefly summarize your trial's design for our listeners?
Yeah, the purpose of the trial was to determine if concurrent oral metronidazole given with topical clindamycin cream, both twice daily for 7 days, to male partners of women who were receiving first-line therapy for BV compared to our current global standard of care, female treatment only, reduced the risk of recurrence in the 12 weeks after randomisation. So it was a randomised controlled trial. It was not placebo controlled, and we can go into the reasons for that. Women were eligible if they were 18 years or older, had symptomatic BV with 3 to 4 Amsel's criteria and a unit score of 4 to 10, which now everyone understands, had a regular male partner for 8 weeks and no other partners. And then they could refer their male partner if he was also over 18. He didn't have other concurrent partners, no allergies to either antibiotics for him because he was the one that was being randomised. And he needed to be able to enrol within a week of his female partner. So you can already start to see how difficult this study is to get the man at the right time with the woman and get everyone to agree to do this study, to be randomised and to be followed for 12 weeks during a COVID pandemic. The intervention was specifically designed to clear BV bacteria from the urethral site, so this was the purpose behind the oral metronidazole, and to clear the BV bacteria from the cutaneous penile site, and particularly under the foreskin, and so this was the reason for the topical clindamycin. And we chose clindamycin because of its efficacy against BV bacteria in the vagina, in vaginal studies, and also for evidence in our pilots, because we did 2 pilots before we proceeded with the trial to look at acceptability, tolerability, and clearance of BV bacteria in men weekly for a month, but also monthly for 3 months. Now, the control arm received global standard of care, and that is female-only treatment. And I know I'm using the words female and male in this just for simplicity, but if you go to our website, we talk about people with penises and people with vaginas. It's just a little hard to sort of say that in the recording, but that I mean that in an inclusive way. And couples were randomised to partner treatment or global practice, and randomisation at the study sites occurred also by IUD use and circumcision status, because these are 2 big risk factors. And as I said, the primary outcome was BV recurrence. That was within 12 weeks. So we had to try and keep these couples in for 3 months. And that was also defined as 3 to 4 Amsel's criteria and a Nugent score of 4 to 10. And so we looked at cumulative recurrence rates and time to recurrence by arm, hazard ratios by Cox regression, and we stratified all our data by IUDs and circumcision status. And we had a range of secondary outcomes, Nugent outcomes, microbiota outcomes, which I won't go into. And we aimed to recruit 342 couples, but we built in an interim analysis to be undertaken by an independent data safety monitoring board once we got to 150 couples. And that had a really conservative stopping rule. So it could be stopped if the p-value was less than 0.0001. And it was stopped.
I guess you probably were not expecting that.
No, it was a relief. I mean, to be honest, we had really prepared for this trial for so long. First of all, I avoided doing this trial for a very long time. I knew partners were driving recurrence. It was in every clinical trial I did. Any treatment you give to women, they failed, and ongoing partner was driving that failure. Oof. But the 7 trials that had failed, 6 of them had failed due to significant limitations, and these were done in the 80s and 90s. The 7th failed probably because it only used oral metronidazole, because it was beautifully done and it addressed all the limitations of the previous studies. Yeah. So it really was a case of, this is ridiculous. We have to do this trial and prove this, because the failure of the other trials was that the 6 first trials were subject to systematic review in around 2012 by, in fact, Supriya Mehta, who did the other penile microbiota study, and that showed it was associated with incident BV. And she showed that these trials failed due to really significant limitations like lack of sample size calculations, unusual therapies, this, that, and the other. And also they failed probably because it's really hard to get men to do these studies. It's really hard to get people to close their relationships. Remember, you're recruiting in STD clinic populations. You're also recruiting women who are highly motivated. And why are they motivated? Because they're desperate. So 90% of women in our studies had highly recurrent BV. 80% had an uncircumcised partner, and then 30% had IUDs. And IUDs, particularly copper IUDs, are this huge risk factor for BV. So you are set up to fail. You get people who are desperate, who have multiple risk factors where you feel, oh my God, is this 1 week intervention to men? Is this actually going to work in this population? You need to be doing it in women who come in for the first time with BV, acute BV, never had it before, brand new partner. We see them in clinic all the time. I've got this awful thing. I don't know what it is. I hooked up with a guy last week and surprise, surprise, incubation periods, 3 to 4 days, which it is for bacterial STIs. And so it's very obvious in clinical practice that this is very strongly associated with exposure to a new partner for the first episode or an acute episode. And that's the group you really want to give partner treatment to before they have an entrenched biofilm. So what I can say is the fact that it worked in this population frankly means it's going to work even better in women with less entrenched BV.
For you, it was sort of the trial that you knew you had to do, but you really didn't want to do.
Didn't want to.
So, but thank goodness you did it. And you did it so well. Like this time you chose the right intervention. Your couple stayed together long enough to get the outcomes data, etc.
So on a practical note, how long did it take you to secure funding for the trial? And was it particularly hard to recruit, or wasn't it hard to recruit in the setting it was conducted in?
Yes, we really carefully built this body of evidence over a really long time and embarked on pilot studies. So by the time we went to apply for funding for the trial, we had some really strong evidence. We applied to the National Health and Medical Research Council, which is like the MRC in the UK and the NIH in the US. We got it second time round. So that was pretty good. But it doesn't mean that we hadn't had years of applying for funding for all the preceding stuff and often hadn't got it at all because it is in Australia. We only have a population of 25 million and your grants get reviewed by generalists. So you have a really unusual grant system where people review your grants who know nothing at all about it. They've never heard of BV. And, you know, I will review grants and I will be moving from cardiology to rheumatology to psychiatry. It's ridiculous.
And I really do wonder, because when we try to do urinary tract infection research, you know, a lower UTI really doesn't kill you. And BV doesn't kill anybody, right? I can imagine
it sort of
for
does
somebody
by HIV, but you're right. You know, you're
fair enough.
competing against
Long term, sure.
No.
But a generalist may not appreciate that right away and might say, "Hey, there's limited funding here. I've got to give it to the bigger killers," right?
That's exactly what happens, and it's really depressing to start a grant with an extensive definition of what you're actually studying. That's the bit I have absolutely hated. I will sit here writing my grants. My husband works on malaria. He doesn't have to tell people what malaria is. It's done and dusted in one sentence. Here's me discussing it. It's not a single cause, and it does this and it does that. This goes up, this goes down. It's really difficult to get funding, and yet it's just amplified by the fact that it is, yes, a female condition. Then when you say, what does it do? Oh, well, a smell and an odour. Well, it does a lot more than that, because it sets you up for really awful sexual and reproductive health sequelae. But none of that's very immediate or very obvious. So it's hard.
Yeah.
So recruitment was really hard. There were a whole lot of considerations and agonising over designing this study. How long do you follow couples for? You've got to follow them for long enough to get your outcome, but not too long enough for other people to have additional concurrent partners, disclosed or undisclosed, and breaking up from their relationships, which also happened. Yeah. We just wanted to follow everyone for a month, and we probably could have, but I wanted to prove a sustained effect to this intervention. But you can't follow people forever. It's really onerous doing it. So we settled in the end on 3 months being the sweet spot. But we wanted couples that were going to stay together. So if you recruit people who have just hooked up, break up, particularly when you have that conversation about BV. So we learnt pretty quickly how to have conversations about sharing good bacteria and bad bacteria. And that's what happens when humans share drinks and they shake hands and they kiss and then they have sex. You know, normal living humans living on a planet with bacteria and viruses. This is a dynamic process. So you have to be able to have that conversation in a sensitive, non-stigmatizing, inclusive way. You have to try and get couples at a point where they're invested in their relationship and it isn't too much of a discussion to have, so that one or both of them walk away. And then you want them to actually be able to be together. To top it off, you have to say, we don't actually know whether this works. So this is a scientific hypothesis and we're going to randomize you. So you don't know what you're going to get until the computer tells us. And if you get randomized to the control group and she experiences recurrence, we'll give you compassionate access to partner treatment. Well, we had plenty of patients who know this is sexually transmitted and then they get randomized to the control group. Great. Yeah. So they're devastated. Yeah. It was difficult for so many reasons. So we have a website that we call BV in Focus that we've designed to provide all the information for healthcare professionals, consumers, and we've got videos on there from couples who agreed to talk about their experience. And wonderful. It was really lovely. I was talking about all the reasons why the trial was horrid to do, but the people in the trial, they were spectacular. They were really supportive. And a lot of people, we did qualitative studies after this with participants. Men talked about this making them closer to their partners and women talking about it being closer, creating a bonding experience, because we also tried to synchronize treatment and talk about not having unprotected sex till you'd finished the treatment. So they had to actually discuss this. It had to be a partnership, really, for this to work. Otherwise, it's going to undermine the intervention. Just like it would be for chlamydia. There's no point in one person taking chlamydia treatment, the other then having unprotected sex with their partner and their partner taking treatment a month later.
So, Kat, again, before we get into the results, which we obviously are really excited to hear, you explain in the paper that the reason that the trial could not be blinded and placebo-controlled was that you said a placebo cream wasn't used because you had a concern that the application of any topical cream, whether antimicrobial or not, could alter the composition of the penile microbiome. Did reviewers still give you a hard time for that, or did they think that the way you defined BV recurrence with these AMSL criteria and the Nugent score, was that enough for them to accept an open label intervention?
Yeah, so that was another challenge, thinking about doing the study. So that was at least a year of thinking about that. Would I dare do a study that wasn't double-blinded, placebo-controlled? Now, the problem with that, the placebo, was not only any potential chemical effect, but the mechanical effect of rubbing cream on the penis twice daily for 7 days. Well, it's like cleaning vigorously. It's going to take off the BV bacteria. If you're doing this sort of twice a day, you're going to alter your endpoint. So it's going to have an effect. Whether it's small or large is unknown, but this study, remember, we're doing the 8th partner treatment trial. If this fails, that's the nail in the coffin. People had already taken the previous trials as evidence that BV was not sexually transmitted. Wow. It wasn't taken as evidence that the trials didn't work. It was taken as evidence that BV is not an STI. That was written in every major guideline in every country. And so we had this one opportunity to see if this was going to work. And we have this, gold standard design of the double-blinded placebo-controlled trial with men popping a placebo pill twice a day in a cream. And that's what I wanted to do. But I'd had an experience with a vaginal placebo that had really put me off, really made me worry about the influence of that placebo on the vaginal microbiota. And I just wasn't prepared to take that risk. So I did discuss it with people randomly at conferences. And my team agonized over placebo, duration of follow-up, what was the end point? Should we drag everyone back in? It would be so easy to do a Nugent endpoint so that if we get people who can't come back, We've still got their slides because self-collected slides are just as good, but I've got to get them back in. So there are all these little decisions, which of course everybody has when they're designing a trial, but they get you bogged for months because you know that if you make the wrong decision, that could sink your trial. So we explained that the New England Journal gives you 2,700 words. There's no room for explanation for anything at all. I've never struggled to write something. It was like bare bones results, bare bones everything, no room for interpretation in the discussion. So I couldn't write a little essay on the placebo, which I wanted to do. One reviewer, there were 5 asked, I think, but people accepted it. They were fine. I think it was reviewed really beautifully by people who really understood the field. And I think, quite frankly, you see those Kaplan-Meier survival curves with a small number of people and you go, oh, that's not a marginal effect. Yeah. So I think the data, fortunately, weren't marginal. And so that helped.
So now, can you spill the beans? Can you tell us the results? At that interim analysis where the DSMB, the Data Safety Monitoring Board, is looking at these first 150 couples, what did they find?
There was a very, very significant difference between the groups. I could tell you our final analysis, but yes, a very big difference. It was Group A versus Group B. So one was better, one was worse. But really, there was a really quite large effect size. So we're talking about a hazard ratio of about 0.36 to 0.38, depending on whether you got your modified intention to treat or your protocol. P-value was less than 0.0001. I think what is really important is it was very robust to any missing data, whether we imputed it as all cured or failed. It was very robust across the stratified groups as well. So when we looked at it, we saw an effect in the presence of IUDs, in the presence of lack of circumcision. We had smaller numbers of men who were circumcised, and we looked particularly at IUD type. So we had smaller numbers with a copper IUD. But what we did conclusively show is this intervention works with uncircumcised partners who are your big risk, with a big load under their foreskin, and it works in women with an IUD, although women with an IUD are overrepresented in women who experience treatment failure. The other thing that was very important was in our pilot study, so we had 50 couples in our pilot studies, and we always have adherence around 92, 93% self-reported, but high rates of adherence reported. In men, we had about, I think it was like mid-80s, 100% adherence to oral metro, and about mid-70s to topical clindamycin, 100% adherence to topical clindamycin. So, all 14 doses. So those are the pilots. Well, when it came to the trial, adherence to clindamycin was a lot lower than metronidazole. Men were clearly remembering to take their tablets, but they're rushing out the door to work and they didn't remember to put their cream on. And so, in fact, only 50% of men took all of their topical clindamycin doses. So we saw stronger effects in our pilots. So Lenka Vostrasil is the epidemiologist in my group and the first author on the paper. She conclusively showed that the lowest recurrence rates in women were in women whose partners were 100% adherence. So 100% adherent to both medications. So they had a recurrence rate of like 1.3 per person years. The control group's 4.1. And so it's a no-brainer. If you take it, it works.
But you had to show it.
You really have to take your medication. And so we have these things that erode the intervention. And so that is poor adherence, particularly in men, particularly to topical clindamycin. So we have to work on that. And that can be related to the messaging, right? We were very balanced about this. We told people we didn't know if it was going to work. So now we tell people it works, but you've got to take all of it. If you don't, it won't work. So that's a very different message. And we also say, if you miss the morning, just keep going so you've taken a full 14 doses. I do wonder whether it is so sensitive to adherence, whether, in fact, men need a bit more drug. I think women probably need a bit more drug too. I think this is a biofilm disease, where longer durations of therapy are probably needed for women and perhaps for some men. And I think we're lucky to have seen that effect. But I wonder if more drug would be helpful. We also know that some people had unprotected sex during treatment. Not a lot, but some did. And some people reported concurrent partnerships. So we said to people, we have to treat a closed couple unit. We didn't use the word monogamy. We have to treat a closed couple unit where everyone's treated in this sexual relationship. So if there are other partners that are untreated, they're just going to reintroduce those bacteria and cause failure, which will then mean we think it doesn't work. If you are having other partners, your questionnaires are confidential. Please document it in your questionnaires. They're not shared with partners, and then we know why something hasn't worked. So there were disclosed and undisclosed concurrent partnerships as well. So you can see I'm grateful that we got the effect size that we did, because there were a whole lot of things that were operating to undermine it. But yeah, it's quite a simple study, but not simple to do.
In terms of kind of real life applicability as well, I mean, those things are all going to matter in real life, aren't they? In terms of men forgetting to put the cream on and the undisclosed partnerships. And I think the effect size is so big that it's nice to know that despite potentially those real world things that are going to happen, there is still really that effect size to be seen. I think as well, what you say now versus what you could say in the trial in terms of being neutral about whether it's going to work. It could be quite a powerful message, couldn't it, in terms of those couple partnerships, to be like, we know this really works, but you have to do it every day. I can imagine the partner being like, do the cream, I don't want to get this again. Use all the cream, and reminding each other and doing that as kind of like a treatment together and to get the best outcome, rather than it being solely reliant on the woman as it is at the moment to fix her problem.
Yeah, I mean, a theme that comes out of this trial, but also the qualitative studies, that women are most affected psychologically and in their relationships when they've had recurrent BV and endless cycles of antibiotics and endless visits to doctors. For the women that experience cure and their partners who experience that previous journey with them, they would say things like, a week of inconvenience is nothing compared to what we went through before this. And it is only a week. I don't know about you, but I treat mycoplasma genitalium, and we are really in between a rock and a hard place with that. And we're doing a lot longer regimens for people. And BV, this is not a weird concept. The fact that partner treatment reduces recurrence, proves reinfection is driving the majority, not all, but the majority of recurrence, or perhaps we should call it treatment failure. And that proves BV sexually transmitted. So then we treat it like that and we discuss it like that. I think it's really time to stop with this opaque language. I think we're doing women a great disservice now. To call it an imbalance of their bacteria sends them off down rabbit holes trying to restore their imbalance with yogurt and vinegar douches and all sorts of home therapies, because there's something wrong with them and they're out of whack. And it's a transmission event that has resulted in BV. If they have ongoing BV, that is another matter. We've proven that reinfection is driving a lot of recurrence, but we are looking at the women who experience treatment failure. Now, we know some of the reasons are the men didn't finish their treatment. The women didn't finish the treatment. They had unprotected sex during treatment. There were other partners, etc. But there's a group of women there who still have BV at day 8. And day 8 was the day after they finished treatment and they had not resumed sex. And we call them the persisters. So I think the great thing about this trial is that it's helped us understand the pathogenesis of treatment failure. We now understand reinfection driving recurrence. So now we've got our persister group. Well, IUD users are overrepresented in that group. That's a bit of a no-brainer, biofilm, foreign body, etc. So now we can start to direct our strategies at those women. Do we need longer durations of therapy for them? Do we need to remove their IUD, treat, cure, treat their partner, then they're going to have it back in? So there's going to be a group of women that need more aggressive therapy, and that's fine. I feel like we were treating everyone the same way, very unsatisfactorily, with multiple rounds of antibiotics directed at women. We can now cure a large group of them, and now we're left with a residual group that we can develop evidence-based strategies to cure them too, so we can achieve cure for all women.
We've talked a little bit about the women who hadn't responded by day 8 and persistent BV despite sort of standard of care treatment. Can you tell us a little bit about potential future treatment possibilities that may be on the horizon or in studies around microbiota replacement or live biotherapeutic products that potentially show some promise for these women?
Yeah. First of all, there's been a lot of probiotics looked at over time, and it's been fairly clear through systematic review that there have been fairly significant limitations with the trials and the products until Lactin V came along, and that is truly a vaginal species, Lactobacillus crispatus. Craig Cohen led the studies in Western Kenya on that product, and women were treated. I think this is the key. There's been no convincing evidence that any live biotherapeutic works well on its own. It really is very much about using it as an adjunctive agent to antibiotics. So using antibiotics to clear your bacteria and then come in. So he did that with an intermittent regimen, and his effect size over 12 weeks was about 30%. It was really good. Mm-hmm. This was in all women, though. This was not in women with just a regular partner, so it was all comers. Interestingly, the lactobacillus probiotic sustained colonization was really affected by unprotected sex. So I think that's a really important thing. The key to doing these things is it's money and expensive, and that product has to be manufactured. It's not something you can just buy like clindamycin cream and rebadge. You've actually got to get funding for the manufacturing of it. I really think there's a real role for the right live biotherapeutic following an effective antimicrobial regimen. And as I alluded to before, I'm not convinced that we have landed on exactly the right duration of therapy for our primary regimen necessarily either yet. I think it's something that we need to all be open to and consider. In terms of things like vaginal microbiota transplant, where Caroline Mitchell from Boston works on that, I mean, that is a really interesting concept. I think there were 4 cases reported originally from a study in Israel, and that follows very much along the lines of it's not just the bugs, but giving it as a package is going to be more effective. And that's had variable success.
Actually, there's some really nice parallels with C. diff and the fecal microbiota transplant. Other conditions that traditionally have been that kind of, maybe it's dysbiosis and you need to replace not just one thing, but a whole niche of organisms. So we have touched on quite a few of the applicability and challenges of implementing these studies' findings in practice around partner adherence and keeping the relationship. What are the other challenges you think might limit the applicability of this study's findings? I specifically wondered what you thought about ethnicity and how that may play a role in BV.
Yeah, there's been a lot of debate about ethnicity and BV, hasn't there? Ethnicity can get tangled up with practices like vaginal cleansing and douching practices that are obviously not great for your lactobacilli. They don't necessarily give you BV, but they might set you up to have a less effective host defence system. But we also have examples very much of ethnic associations that are related to really terrible access to healthcare in some countries, particularly. So people who are most affected come from certain ethnic groups where there's no access to healthcare for them. So they have a whole lot of things, lots of STIs as well as BV and other things. So I've touched on this before, but I think that first of all, if this study worked in this population who were really set up to recur, I feel confident that the intervention works. But you do, like you do for all STIs, you know, if you have open relationships and people are getting exposed, you are going to not derive the same benefit as you would in a closed monogamous relationship. One of the questions I think is, so we're using our samples not only to start to look for the cause of BV, but we're also using our samples to see, is there a predictive penile microbiome profile for BV recurrence? Are there BV bacteria that predict recurrence? Then you can develop a test. Then you can test men Then you have the world's first true prevention strategy to prevent women from acquiring BV to begin with, not just prevent recurrence, but prevent acquisition. So obviously that's like a very big thing, and that comes with all the issues around antibiotic use and stewardship and this and that. But we don't actually know what the prevalence of these bugs are in the general population. In men, we know that chlamydia is sitting at around 1 or 2%. We measure all of these things and we report them, so we know your probability of encountering that if you casually go out and have sex with someone is 1 or 2%. Well, what is it for BV? It's a lot higher for absolute sure. So when we talk about the challenges in the applicability of our study findings and ethnicity, it's going to depend really on behaviours in populations, so sexual behaviours, relationship behaviours, carriage, prevalence, all of these sorts of things. So we need to do these studies. I think what this tells you is in high income, well-resourced urban setting, with people with reasonable health literacy, this intervention works.
Yeah.
I think that we need to reproduce this in different populations, and yes, it will have different effects for all of the reasons we've discussed today, because you're going to have a whole lot of different societal factors operating. But as I said, I think the other thing about it is you've really got to be open about BV and use clear language so women and men understand.
Okay, this is my antibiotic steward hat. Have you, in this trial, had the time to look at resistance outcomes? What could be unintended consequences?
Exactly. Particularly with clindamycin.
Yeah. Are you going to be looking in that cohort?
We can. Well, I think actually for clindamycin, it does just depend. We obviously have missed the boat for all the traditional sort of cultivation-based studies and MICs. So we would really have to look at markers of resistance. And we know metronidazole really isn't associated with significant resistance issues for the BV bacteria. There's some intrinsic resistance. Clindamycin is a much worse agent to be using. So I think it is really important, particularly if you start to think about scaling up of testing and developing a diagnostic test, etc.
So Kat, going back to the trial and all the work you had to do for it, it was very obviously a highly successful trial. But there's always something you might want to do differently afterwards. Was there anything in this case that you would have done differently?
Not doing a trial during a COVID pandemic would be one. Providing more material to assist women with discussing BV with partners, I think from the very outset, is really important. Really hammer home adherence to men. I would say hammer it home to women, but women are motivated because they're symptomatic. I'd like to say I'd do a pile of things differently, but with the funds available and all the constraints of a randomised controlled trial, where you have to be balanced and tell patients you don't know if it's going to work, you always go, gee, I wish I had more. We've got lovely microbiota samples, but gee, I wish I had samples for AMR. But you also have to just go, I can't over-collect. Think about how you're going to use it in an analysis. If you're not going to use it in analysis, don't put it in. It's not fair. So we keep questionnaires quite short. We keep sampling to the minimum important samples so that we are not overburdening our patients, which contributes to dropout and loss to follow-up.
So, Kat, we've heard a lot about BV. If you had the $1 million, maybe lots of millions, how would you spend that money to answer the big unanswered question in BV?
Well, I think if we just distill it down to one big unanswered question, we still don't know what the cause is, the exact cause. That's ridiculous, isn't it? We don't know if it's caused by a single pathogen or a polymicrobial consortium from the outset that displays optimal lactose, or if lactodepletion occurs first, enabling overgrowth of BV bacteria. Most of us are starting to feel it's a pathogenic strain of Gunnarella vaginalis that's transmitted. We're going to be using our samples from our trial to really try and understand causation. See if there is a predictive penile microbiome or penile BV bacteria that are predictive of recurrence in women, which then really helps to address that sort of whole causation issue. So that's the one big unanswered question, because once you've done that, you can then develop better targeted diagnostics, which we know are lacking, more targeted therapeutic agents as well. You can develop tests for men that enable you to test, treat, eradicate, prevent BV in women, that you can truly impact the global burden of BV. You can prevent pregnancy sequelae. You can develop vaccines. So this is like, for me, the starting point, really.
For other recurrent infections in women, even those that are still not considered to be sexually transmitted, I have a certain amount of women patients who get recurrent UTI who tell me, with this partner, I get UTIs, and with my ex, I didn't, or vice versa. And I have been asked by some patients, could you please treat my partner too? But it's completely uncharted territory for UTI. What do you think about that?
I agree with your patients wholeheartedly. And I think, obviously, in medicine, we are supposed to do our randomized controlled trials and all of these things. And we're not supposed to function based on anecdotes. But the worst thing you can do is ignore what your patients tell you, because it's their lived experience. I've heard the same thing. I am completely on board. It's something we are very much planning to do, because I think it's doing women a great disservice telling them repeatedly, really with lack of evidence, that it's actually your own bacteria that are giving you a UTI, and it's just the mechanical action of sex that causes them to migrate up a short urethra into your bladder. We were all taught that. We're still telling patients that, just like we told them BV wasn't sexually transmitted. I actually think that it's time to overturn that myth. So if you want to do a study, we're on board, because we're planning to as well. So we can do a multi-site.
My patients would love that. Yeah. I think you're right. We owe this to them, and it's completely understudied, and we need to do it. Do you have any last message or messages for our listeners?
Yeah, look, I think this is a big paradigm shift in knowledge and in clinical practice. It is a little bit overwhelming, particularly for primary healthcare providers, but for everyone in their busy practice. So we put a lot of effort in the last 6 months into designing a lot of information around helping consumers discuss BV with their partners, and information for clinicians, information for pharmacists. And we've put all of this on our BV in Focus website. A lot of this is downloadable, and it's there to enable people to confidently discuss the evidence and the intervention with their patients, and to give people information. And it includes things like a letter for pharmacists that you can print out with your prescription, so that the pharmacist doesn't go, what the hell have I just been given, a vaginal clindamycin script to a man? So we're trying to mitigate all the issues. And once we've changed guidelines, then we can start lobbying the pharmaceutical company behind the product, so that we could have a product that was just clindamycin cream and doesn't say vaginal with 6 applicators on it in a box. And one last message, don't forget the condom. Condoms prevent transmission of BV. We published a meta-analysis in 2008 showing that. I know they're not very fashionable, but they are very cheap, and they have very broad-reaching effects against STIs, of which BV is one of them. And it is something you can do to prevent acquisition or catching it, but also to prevent recurrence as well.
Yes, very good point.
Yeah, we need to make condoms cool again.
We do. In our pandemic of STIs, they're just going upwards at the moment.
Kat, thank you so much again. Catriona Bradshaw at Monash University in Melbourne, Australia. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Annie Joseph in Nottingham, UK, and me, Angela Huttner, in Geneva, Switzerland, editors at CMI Comms, ESCMID's open access journal. It was edited and produced by Dr. Katie Hostetler-Oy and peer-reviewed by Dr. Ariana Zerja from Mother Teresa University Hospital in Tirana, Albania. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks. And all the literature we've discussed today, as well as the websites that Kat has mentioned, can be found in the show notes. You can subscribe to Communicable wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.